introduce you. Good morning, good afternoon, and perhaps good night, evening to you colleagues. This is a lecture. I think we have 3 more lectures to finish our 15 lecture series. So this is lecture number 12, which is about how to use information from IR. And the speaker for this lecture is Dr. Humayra Anwar from University of Brak in Bangladesh. Without further ado, I invite you, Dr. Humayra, to start the lecture. Thank you.
So hello, everyone. Sorry, I just had a power cut and now the, generator has started. So yeah, I'm sorry for the inconvenience. So I think you can hear me and you can see me, everybody.
Yes, we can see you well and we can hear you as well.
Okay, thank you very much. So let me go to the presentation mode. So as already Dr. Aman has introduced me, that I'm Dr. Humayra Binte Anwar from Brak James Sprague School of Public Health, Brak University. So good evening from Bangladesh, everyone. So I think that you have already learned a lot about the implementation research, isn't it? I think you have learned about the what is implementation research and, what are the approaches, different study design, implementation outcomes, models, frameworks, lots of things. So today we will be talking about that how we can improve the quality of an intervention. How can we improve the quality of the implementation process of an intervention through the information we get from the implementation research and also from the other quality improvement approaches. So we will be focusing on the iterative cycles, iterative learning cycles that help us to design and also, improve the implementation strategies so that we can, inform the stakeholders about their, current status of the implementation process and why we do that. What is our goal in implementation research? Our goal is maximizing the effect of the intervention we are having in both long and short term, isn't it? So is there someone agree with me? Apart from Manas, who else is listening?
We are here.
You can talk.
Yes. So please respond to me. Otherwise, I'm feeling like alone in a power cut. Okay. So let's move on. So in this chapter, as I said, we will describe the iterative learning process of plan, do, study, act cycle and how we can use it. And we will also describe the learning evaluation approaches for improving the implementation process. And also we will try to give an example of this PDSS cycle from a case study from Ghana. Okay? So let's move on. So now we all know that the implementation research is very dynamic and adaptive in nature, isn't it? So we can say that implementation research needs continuous learning and it needs to give continuous feedback to its stakeholders and to the team so that they can address immediate implementation problems and also they can facilitate adaptation. Now, if I want to give an example regarding that, I can give an example from Bangladesh that you all know that Bangladesh expanded program immunization. It's very globally successful. So, but yet there are some pockets where we have, low immunization coverage comparatively. So what government did, they launched and piloted a digital app which is called e-tracker, and this e-tracker with their development partners, of course. And what does this e-tracker do? This e-tracker does, through this e-tracker, the vaccinator can enter do the online registration. And when they can, do the online registration, they can track the children who are coming, who are not coming, everything. And also through this tracker, they can send SMS alert or notification to the parents that please come tomorrow or on that day because you have a vaccination for your child, etc., etc. So, but they piloted this in Dhaka and also outside of Dhaka. But outside Dhaka, what happened? That I'm now outside Dhaka, and now the power cut happened. So the same thing happened to the vaccinator as well. When they are working, there is no network. When there is power cut, the internet network doesn't work, and the internet network is not so good there. And also, this is a digital app, so when sometimes the tab is broken, so you have to fix the tab, and there is no technical person out there in the rural areas. So those were the immediate implementation problems. And also the vaccinator who are a bit older than others, they have the issue with the getting adapted to the digital app. So that's why we need this for to address those immediate implementation problem. Is that clear to everyone? Does anyone want to add anything? Any example from your country?
Colleagues, you can talk.
Yeah. Okay. Okay. So I think nobody has anything. So I am going.
There is a comment
Okay.
which
Okay.
really is saying that is great. Share some information on tracker. Any link to
Yeah.
learn more
You
immunization tracker?
Yeah, I'm currently working on the manuscript, and it's under review. So I will be sharing that soon when it gets published, okay? So yeah, finger crossed.
Thank you.
So, and then the implementation research should inform the broader and long-term learning and actions. What are the broader and long-term learning action? They are the scaling up and also the integration of effective intervention into the existing system. And also we can routinize the effective implementation process, and the best practice also can transfer the IR evidence to policy. So can anyone give an example to me regarding this? We have lots of example. Anyone from our students? Oni, are you there?
Yes, Apo.
Yeah, can you give an example? I think we have learned a lot of example.
Yes, we have, but I
Yeah.
can't come up with one right now.
Okay. So no problem. So what example I can give is the Global Polio Eradication Initiative. This is a very popular program worldwide. If someone doesn't know, but it is a very popular and a very big public health initiative. And initially, it had lots of challenges throughout the world, but then it covered up all those challenges through, continuous improvement. And now it is one of the biggest public health initiative. In Bangladesh, if I want to say that if in Bangladesh, those polio campaigns were very successful and trusted by the community. So the government scaled those up, and it is to happen twice annually, and up to the certification. And then also the government integrated vitamin A supplement and the deworming with it, so that those coverage also gets increased. And that happened because the people trusted the polio campaign. So along with that, they also took those intervention as well. And ultimately also, so those are scaling up and integration. And also there are some best practice in that like doing micro planning, doing community engagement with religious leader. Those became the best practice. Okay. Everyone clear? I think. Okay. Then also this whole process of translating implementation research to both short and long-term action, this thing can be also studied as implementation research, but it should have the well-defined implementation outcomes, which should be linked with the impact. Can anyone say what are the implementation outcomes? Help me to remember. Anyone would like to say? We know the implementation outcome. We had them in implementation research lecture series already. Anyone? Okay. So if anyone, okay, is there
Fidelity
anyone want to?
is correct. Riri has mentioned fidelity, which is correct.
Okay, why I can't
What
see
else?
the,
Okay, all
I
right.
can't
We'll
see
move on.
the chats. Oh, no.
I'll
Yeah,
read that for you.
okay. Yeah, fidelity, feasibility, acceptability, all these things, you know, adaptability. So here, if I want to give an example, suppose this is an example, this is not from a journal or paper, we want to improve the antenatal care of a rural community, antenatal care utilization among the pregnant women in a rural community. So the gap we identified that there is a lack of awareness among the pregnant mothers regarding the ANC care. They do not know about the importance of the ANC care. And also there is limited access to the health facility. So what can be our, you know, short-term action? Can anybody say? I want this lecture to be interactive, but if anybody can answer or you don't understand, please let me know. What could be the short-term action? You can also share in the chat that we want to improve the, you know, antenatal care utilization, but there is a gap that the people doesn't know about it, and there is less access. So yeah, okay. So what we can do is we can introduce a public health campaign, and we also can, you know, arrange some transportation facilities, which can help in short term. And in the long term, we have to ultimately raise the awareness so we can integrate this into the textbook. And then we can also do the advocacy with the government so that the infrastructure of that area, you know, gets better. So this intervention can again be studied through the implementation research for implementation outcomes, that how acceptable the vaccine campaign is, how adoptable the vaccine campaign by the implementers. So these are, and this should be also linked with the impact measure. We have to always see the impact that there is increased utilization of the ANC care. Okay, is that clear? I think someone needs to mute.
Yeah, please move on.
Okay, I don't know why. Okay. So what we know from so far, we know that we need continuous learning and adaptation in implementation research, and also to improve a program, isn't it? So why we need this continuous learning? We need this continuous learning so that we can scale up the evidence-based intervention, isn't it? And scaling up the evidence-based intervention is the major goal of implementation research, we know. So here is a figure that we can see that this is a framework for scaling up given by Berker in 2016. And this describes that how can we scale up an intervention. So it has 4 stages, like set up, then develop the scalable unit, test the scale up, and go to full scale. So for the setup, first either you have a new idea or best practice you want to scale up. Then you have to set up your goal first, that what you want to achieve, what you want to scale up. And then you have to also set up like whom to you are going to apply those intervention first. I assume that you have learned about theory of diffusion. So you have to identify the innovators. You have to identify the early adopters. If we give the example of COVID vaccine, like first we have to target which group. In Bangladesh, we targeted the doctor. We targeted the doctor as the innovators because we gave the vaccine to the doctors first. So then should be the developing the scalable unit. What is the scalable unit? It should be the small replication of the whole scale up thing. So what is the purpose of this? This purpose is to know about the local context, to know about the local area issues. So like in Bangladesh, we started the vaccine to the doctors when it was set up, and we started with the Dhaka division. We started with Dhaka district. And then we have to test the scale up. And during testing scale up, we have to look at this adoption mechanism, the support system, that everything is in place, the data system, the human resource, the other resources, the manpower, the infrastructure, and also the communication leadership, everything is in place. And after testing that, we can go for full scale up, that is replication of that procedure again. So you can see that here, we can see that this is not a linear process, there is other way arrows. So what does it mean? Can anybody guess? What does it mean if we have arrows both sides? Anyone? I don't know whether anyone is listening or not, but okay, so these arrows means these are interactive. Like from one phases, we can learn and take it away to the other phases, and also from the next phases, we can learn and we can, refine the previous phase. Is that clear to everyone?
Yes.
Yes.
Okay, thank you. Thank you for your response. So next, so we have already said that quality improvement is important and we need some adaptive learning tool. What are the learning tools we can, use? One of the very famous learning tool is the learning evaluation cycle. I think most of you will work with learning evaluation cycle soon when you will be working in a program or in a bigger research team. So this learning evaluation cycle, what is the learning evaluation cycle? It is a kind of method, or I would say it's a tool that addresses the bottlenecks of every stages of the implementation process at a regular interval, and it also gives the feedback to the stakeholders in real world. So one of those kind of learning cycle is the quality improvement approach. The learning evaluation cycle uses the quality improvement approaches. And what is the quality improvement approach? It is the small rapid test of change in real time, and through this we get real-time data. Okay, real-time data, continuous real-time data, so that we can monitor that this change is happening or not. Okay, and this implementation research and quality improvement approach, they provide theories that inform the further implementation, and also we can produce knowledge which can be generalizable in other contexts too, and that is also a goal for implementation research. So now let's see that what is the quality improvement approach we use the most. This is one of the most used, in also in monitoring evaluation and also in learning evaluation. So there is a model of improvement, and it has two, component. One is the model of one is the for some fundamental question, and other is the action cycle. So in the fundamental question, what we have? First, we have what are we trying to accomplish? Again, we have to set the goal first. That is what it means. Then how will we know that the change is an improvement? How will we know that the change is happening? So for that, we have to, I think, set some measures. In the we learned in monitoring evaluation that we have to set some measures to track the performance, that improvement is happening. So like outcome measures, and then process measures we can fix. And then number 3, what changes can we make that will result in an improvement? So you want to accomplish something, for that you have to come up with some changes. So what are the changes? How can we identify? You have to identify it according to your objective, and you can brainstorm with your team, or you can have critical thinking, of course, with your team. Then when you decide the key changes, you have to enter into the action cycle. And the action cycle has 4 things, that is plan, do, study, act. Planning is planning, that who, what, where, why, and how we are going to implement. Then do is the implementing the thing, but in a small scale. First, in a small scale. Then study. Then again, you have to analyze, collect the data and analyze the data, that what is happening, is there any improvement, or is there any refinement needed? And then if there is any refinement needed, then in the act cycle, you can refine that idea. Or if the idea didn't work at all, then you can abandon that idea. Okay, this is the PDSS cycle. Is that clear to everyone?
Yeah.
Yes.
Okay, thank you very much, Elena, Luis. You're a good listener and good participant. Thank you. So now, I want to give an example. Like it's just in Africa, as we are also giving the case study about Ghana. So I think Africa would be good, because in Africa, in some of the provinces, yet there are, high maternal mortality rate, and mostly it is because of the lack of the skill of the, healthcare provider. So what will the model of improvement? What will the question? What are we trying to accomplish? Can anybody tell us that what are we trying to accomplish? What is our goal here? If you have a high mortality, maternal mortality, what is your goal? What do you want to achieve?
Reduce the maternal mortality rate.
Yes, we have to reduce the maternal mortality rate. Very good. So we have to set a target. Like we have to, reduce the maternal. This is just an example. We have to reduce the maternal mortality rate by 25% within 2 years. It should be feasible goal. Then how will we know that a change is an improvement? As I say, that we should set some measures. And what are the measures for reducing maternal mortality? It could be like the number of maternal deaths happening, the percentage of women receiving the antenatal care, and also the skilled birth percentage of births attended by the skilled health personnel, institutional delivery rate. All of this can give you the look or give you the thought that it's the change is the improvement. So after that, what changes we can make that will result in an improvement? What changes you want to make? Here already I have said that there is lack of skilled human resource. So what can we do? What strategies we can take? Anyone? When there is lack of skilled manpower? Yeah, Elham, you want to say?
I am not sure about my answer. Just it's sure that we need some education in this regard, and we need trained
Yeah,
we need healthcare resources. So we may
I
start with the education and training the human resources.
okay, very good. So there is lack of skilled manpower. So we have to recruit enough staff, and also we have to train them. In Bangladesh, if you ask any doctor who is in government service, you will get the same answer, that we don't have enough human resource. I think it's a common scenario all over the LMICs, isn't it? So I think we can provide enough staff there, and also we can train the staff. You are very correct. Thank you for your answer. So what is our plan? As I say, why, where, when? So we have to establish all this. We have to plan for recruiting the staff. We have to develop the training module where we are going to, give the training, how, frequency, everything. We have to decide here. And then we have to recruit. We have to recruit, and then we have to train them. Then from the study, we can collect the data from the intervention, that's what's going on there. And after collecting the data, we can analyze the data, that what is the impact of the program, what is happening there. So, and also we can do that by collecting also monitoring data, and also we can interview some person. We can get some feedback that this is working or not, that how many people, also we can check the list that how many people, how many health workers are attending in those, training session, and what is their feedback, what is the feedback from the trainers, are the trainers following the guidelines or not. So we can study all this, and then we can refine the training program. Suppose that they are giving the training, but the guidelines, they are not maintaining the guideline, or the health workers are not attending or not listening to the sessions. So we should do the continuous monitoring and then refine that one again, and we can run the cycle again. Okay, is that clear?
Yeah.
Thank you very much. So now we know that we need continuous improvement to test an intervention in a local context. So what about if there is a bigger context? What about if there is another context, different context, different countries? So here is a model. This is called BTS model. It is developed by the International Healthcare Institute and by Barker, 2015. So this is a model that they're showing that we have to start with a very small scale test, and then we have to have that iterative PDS cycle again and again, and then ultimately we can test the changes in a large scale. Okay, so first we have to start with a small scale, like we can start with a small one clinician and one patient, and then we can run the PDS cycle again and again, and ultimately we can test it in a from a larger perspective. Okay, is that okay? Is that understood, everyone?
Yes.
Yes.
So we need PDS cycle for continuous monitoring and continuous improvement, and also to go to test our intervention in larger environment. So till now, I was talking about a single organization. What about it's a very big initiative, like we called it the polio eradication initiative. It was a very big one. Lots of countries in the world was, involved in it. So what if there is multiple organization, you are doing a learning evaluation where multiple organization is there. So learning evaluation cycle is such a method that we can use in both in a single intervention, single organization and multiple organization, because it blends the implementation research and the quality improvement approach so that we can get systemic and transportable finding across the institute. Okay. So if any healthcare institute wants to take part in larger initiative, then the learning evaluation cycle should be designed as a flexible way so that we can do the cross learning, cross organization learning, and also we can, produce transportable lessons. So for that, we have to follow some broader principle, 5 of them. First, we have to gather the data regarding the implementation. And how can we gather the data regarding the implementation? We can gather the data through monitoring data, or from also, interview. You can interview the people. And then after collecting the data should be collected according to the process and outcome. So we already know the process measure and outcome measure should be aligned. And then we have to also assess the multi-level contextual factor, because here multi-level organization is included. So we have to assess the multi-level contextual factor that impacts the broader, broader goal. So we have to identify those. So after that, we have to gather those data and then analyze and synthesize and then make a summary, and we can present those, data, the summary of that report to the organization through a meeting. Those are called learning meetings. So we can share the data with them, and we can also help them so that they can understand the data and they can improve according to their own data. They can learn from their own data. So after that, we have to, when all the organization we have done, then we have to set some common measurement strategies to reach that goal for all the organization. We have to have some common measurement strategies. Okay, is that clear? These are for multiple organization, not for a single organization.
Correct.
For single organization, we have to run the PDSS cycle again and again until we reach the, ultimate goal. But for multiple organization, first you have to do all those things, learning PDSS cycle and collecting the data, and then you have to share the data, and then the PDSS cycle goes on, and then you have to come up with some common strategies. So there it is a picture of such example. Here, you can see that organization 1 to organization N. So multiple organization is involved here. And what we can understand from here, that each organization can have multiple PDSS cycle until they reach to the, the broader goal. They are continuously improving their self. So first there is the collection of data like quantitative and qualitative data. Then there is analyzing and synthesizing data and sharing with the organization. Then there is learning meeting and sharing. And then also cross-organization learning can happen. And ultimately all these processes lead to the improvement of the quality of the implementation process of that intervention, and also the broader goal we can achieve. So anyone has any question regarding this picture? Is there anyone who couldn't understand this picture? This is one organization and this is another, and this is, n number organization. So in each organization, they are running multiple PDSS cycle. until the, quality and the achievable quality improvement. Their expected quality improvement. Anybody has a question? Hello. Nobody has a question?
No, there is no question. You can move on.
Okay. Manas, you can also ask if you want.
Yes, I have a question. So there is intra and cross-organization learning process, right? Between them and across. So how do we ensure that they are aligned? You mentioned that they do have stakeholder meeting and then they share the experience and then they improve on it. Is that how you mentioned?
Yes, they do cost sharing. Sometimes also they do some stakeholder engagement meeting. And
Okay.
also sometimes they can also present in relevant conferences. Okay.
All right. Thanks.
Okay.
Because I guess the context could be different.
Yes,
For example,
of
for
course.
polio eradication, for example, in Pakistan compared to Nigeria to, other countries, it could be different. So I guess they can learn some aspect that we do it like this here in Nigeria because culturally this is acceptable. Or in this context, we do the routine, for example, case detection for polio, we do it this way. However, in Pakistan, it could be different, right?
Yes, of course.
Okay, understood.
Yeah, thank you. So that's the end. Next, we will have the case study. So what is our take-home message? Can anybody share their take-home message? Only one could be, the volunteer.
Let's ask colleagues who haven't spoken yet. There is no right or wrong answer. Please.
What did you learn? Yeah, just what did you get?
Wrong.
What message you get?
Yes. Implementation process is continuous. And there is need for adaptations.
Exactly.
Okay, thank you very much. So yes, that's my take-home message is also the same.
I have a comment before we go to the last slide. So colleagues, the difference between implementation research and, for example, clinical research or clinical trial is that in clinical trial, you set the objectives, outcomes at the beginning, and then you develop a protocol and you have to adhere to those, objective or the standards of procedure you develop, and you have to adhere to those throughout your research. If you don't, then there is a protocol deviation or violation, right? However, in implementation research, it's a very, iterative process, and you keep learning by doing and improving on it. So at every stage, you can make changes, and the change has to be, of course, evidence-based, because you collect the data, you realize that this process is better, you improve on it, and then you move forward. So that's a really important difference that you can consider for those of you who are very much also involved in clinical trials. Because in clinical trial, if you make changes, you get yourself into trouble, basically. But in implementation research, at every stage you learn and you improve on it and you move forward. And I think this is very important. The second part, Humayra, is that many funders, they give funding for monitoring evaluation. In other words, For example, if you look at Gates Global Funds, they do earmark funding for monitoring evaluation, but they don't give funding for operational implementation research. So those who are very smart, they argue that monitoring and evaluation is like, improving, quality improvement of part of the implementation research, and they use that as a basis for their implementation research. So still many funders, they don't understand the importance of implementation research. So you need to talk the language of the funders when you want to package implementation research into the grant. Maybe you need to talk about monitoring evaluation, although monitoring and evaluation is totally different from implementation research. They are part of the quality improvement of implementation.
Yes.
I think I talked too much. Sorry, I overtook you.
No. You already summarized all the things I said. So, and adding to that, yes, implementation research is different from the monitoring and evaluation. But to achieve the goal, what is our goal? We have to have the evidence-based intervention scaled up, and we want to improve the quality, and then we can scale up. So we need both the implementation research and this.
Okay, I think we lost Humayra, unfortunately.
Monitoring and evaluation, these learning evaluation strategies.
Okay.
Okay.
Maybe you repeat yourself because we lost you in a minute.
Okay. Oh, so I said that adding to Mana's that we need both implementation research and monitoring evaluation for, the improvement of our intervention and to scale it up. Because, monitoring the quality improvement approach, what they do, they look for the effectiveness and efficiency measures that everything is going right. And on the other side, the implementation research, they're doing, they're seeing how the implementation process is going on, what are the barriers, what are the facilitators, everything. So together with the quality improvement approach and with the implementation research, we can achieve our goal, which is to, which is to, scale up the intervention, evidence-based intervention. Okay, is that clear? We need both, not only
Yes.
implementation research, but also monitoring and evaluation.
Exactly.
Yeah.
So monitoring evaluation is part of the implementation research.
Yes. That's distinct, but can be one part. And now this is a case study we have from Ghana that we know in Ghana, we have the high maternal mortality and high child mortality rate, under 5 child mortality rate. So this is a case study that reflects the gap between the evidence-based guideline and the practice of the healthcare in Ghana, despite the availability of the cost-effective intervention. So they have had the cost-effective intervention, but there were some reasons why the intervention wasn't working. So when they found, did the research, they found out some drivers, like primary drivers and secondary drivers. Primary drivers are those that delay in seeking care, and secondary is the associated with delay in seeking care. And also there is a delay in providing care by the healthcare providers. And also there is insufficient use of local data by the decision making. So here, if we run a PDSS cycle, so first was like to delay in seeking care. That means the beneficiaries, they are making delay to get to the health facilities. So what can we do? So they find out, they tested that they conduct community engagement with males to promote the skill delivery. they started testing this to improve the delay. So through survey, they collect the data and gather this knowledge that the main may be the reason that this delay is happening. The pregnant women are not going to the health facilities or delaying going to the health facilities. So in dual cycle, what they did, they conducted 5 advocacy groups where males usually meet up. There is a advocacy group among the males. They can share their, thinkings. And then when they studied this intervention, what happened? They analyzes the data and they saw that these men are more receptive to message from the peers. Maybe they don't listen to the family. Maybe they don't listen to their wife, but they listen to their peers. Same other male community persons from their community. So what they did, then what was the act? Then they expanded this advocacy group. They expanded this advocacy group with peer male members in the community. Another thing they tasted is that they made the health facilities friendlier for laboring women. For that, what they did for 1 month, all the laboring women were welcomed, and the labor workflow was monitored. But when they analyzed the data, it showed that there is still lack of coordination between the beneficiary and the implementers. So what should be their act? Their act was that identifying a responsible health facility staff. They assigned someone with that problem. We always see that whenever in a hospital setting we are working, if something is not working, if you assign somebody who can delegate their work or for that issue, then it will improve because he will do the supervision, the monitoring, everything is happening in the right way, the coordination, the welcoming, everything is there. So they refine that. They identify a responsible person and assign the whole work to him or her. And then implement. Yeah.
Miss ko na lang din. Miss ko na.
Sorry, go on. It's
Okay.
yeah.
So yeah, and then they continue for extra month. So this is a case study. We wanted you to do work with the other 2 additional primary drivers we have, that delay in providing care. So can you identify, here the secondary drivers are also there. Can you identify one of the change you want to make here? Someone. Anyone? Delay in providing care. This is from the implementer side. So there is poor staff attitude and behavior, low risk and awareness, inadequate clinical knowledge skill, protocol unavailability. So you can take lots of measures to change this. Anyone wants to share their idea what they can do? Anyone? Elena, Luis, Elham? No one? So from this, I can share that, yeah, you can, there is a low risk awareness and management. So we can again do a vaccination campaign, or we can train the staff that they do so that they do not delay in providing care, isn't it? So again, there is insufficient use of the local data for decision making, and it is happening because the frontline provider, they do not know how to use data, and there is a collection of poor data, and there is no supervision and monitoring. Nobody is teaching them or supervising them. So what measure can we take against that? Insufficient use of local data. We have it frequent in Bangladesh. Anyone from Bangladesh here? No one. This is where is thing. Just give me one plan you want to do.
Well, I can get the insufficient use of local data for decision making. For
Okay.
example, poor data quality means that they have to train people to collect data routinely and to be able to collect quality data.
Yes, very good. So you're addressing the poor data quality. You have to do the training, isn't it?
We
So then,
only have 5 minutes to go, Humayra.
yeah,
and
I'm just finishing. So if we do the training, if we plan for training for do cycle, we have to train them. And in the study, what we have to do? We have to see whether the training is working or not. It's very simple. And then act, if the training is working, then it's okay. If the training is not working for a reason, then we have to modify that act again and do the PDS cycle run again. Is that clear to everyone?
Yes.
I hope that's clear. So
Yes.
that's the end of my lecture. So anybody has any question
Thank
or
you.
remarks? Anything? I would love to hear from you.
Yes, we have a comment that micro planning can be done.
Yes. For what? Which one you are talking about? Micro planning for micro planning is used for what? To identify the patients. Yes, we can done. And we can, for vaccination, we do it, micro planning, and we identify the children who needs vaccination. And then we go door to door. Same thing we can done for the pregnant woman as well. Yeah, this is a very good suggestion. Thank you for the suggestion.
Yeah.
Thank you, Riri.
Okay. Thank you. If I don't see any hands up, so that's great. Thank you so much for your time. It's very interesting lecture. And I think it's very important. The take-home message is that implementation research is an iterative process. And as you go along, you need to pause and evaluate whether you're on right direction or you need to make modification and move forward. So it's like cyclic. It's not linear process. It's very important, colleagues, to know this. And also you keep improving on every steps. And as Dr. Humayra said, in a single organization compared to multi-organization, the process, the PDSA process in the multi-organization, it's actually not one-to-one, but it can actually be cross-organization. And you share experience with other organizations through a stakeholder engagement, presentations. And the whole idea is quality improvement. And quality improvement is very important because I think you have to remember that in the whole process, we're thinking about implementation research. I hope you remember Professor Malabika's lecture, that we're focusing about implementation outcome, not the actual, public health outcome. It's very important. Great. Thank you so much, Humayra. And thank you all for joining this lecture. We have only 2 more lectures, and then we go on summer break, colleagues. So looking forward to seeing you. So we will have a pause. Thank you for all of you who woke up early and late.
Sorry, I had a power cut still.
Thank you. Bye-bye. Bye.
Bye.
Bye. Thank you.
Bye. Humayra, can we talk on WhatsApp? Just a moment.
Yeah, sure.